rigorous treatment plan with increasing awareness among the patients. The concept of informed consent is also evolving. Like any other healthcare field, sometime unforeseen mishap may occur even after our best efforts. A written signed consent is the only evidence that can save a practitioner in a legal case. In case of mishap, it reduces the risk of dentist being sued for negligence or malpractice. It is the moral and ethical principle that informed consent of the patient is obtained before starting treatment. I have the pleasure today to introduce today's speaker, a dear friend of mine, Dr. George Paul. Dr. George Paul, a consultant and oral and maxillofacial surgeon, a faculty member of Kerala University of Health Sciences, and also honorary adjunct professor in MGR Medical University, Chennai. He has earlier served as a professor in MGR Medical University, Chennai, Rajiv Gandhi University and Health Sciences, Bangalore, and Vinayaka Mission Deemed University, Salem. Dr. George Paul has, to his credit, 25 peer-reviewed national and international publications. He is the author and contributor of 2 books and has been the speaker at numerous national and international conferences, workshops, and seminars. He was the honorary secretary of Association of Oral and Maxillofacial Surgeons of India from the year 2003 to 2007 and the president of the association during 2009. It is pleasing to note that today we have more than 20,000 participants. Over to you, dear Dr. George Paul.
Thank you very much, Dr. Janakraj Sabarwal. It indeed is a great pleasure to share this platform with you. He's a good friend of mine, as he mentioned. In fact, when I was the secretary of the Association of Oral and Maxillofacial Surgeons of India, he's held high positions. Dr. Janakraj Sabarwal has held high positions in both the association as well as in statutory bodies. He's a successful practitioner with more than 40 years of practice in Delhi. He is the director and professor of oral and maxillofacial surgery in the Indraprastha Dental College. This is something that very few people know. He is the chairman for the dental division of the Bureau of Indian Standards. This is a very important organization that sets standards for dental materials as well as gadgets and devices. He is the immediate past president of the Indian Dental Association, the biggest dental association in India today. He's been a member of the Dental Council of India and an executive committee member of the Dental Council. Recently, Dr. Janakraj received a PhD from the Manav Rachna International University and a photo. And he's got a Lifetime Achievement Award by the AOMSI, which granted lifetime achievements to people who have done enormous work for the specialty. He received that in Bangalore last year. So indeed, Dr. Janak, it's a pleasure to share this platform with you. And talking about platforms, I think I need to personally thank the members of the Dental Council of India and the Executive Committee for having thought of the idea of starting these webinars, which has received enormous amount of feedback, and for the leadership of Dr. Dibyendra Majumdar, who conceived the idea, and who also happens to be a good friend of mine for the more than 10 years at least. I've had the opportunity to work with the Dental Council in drafting the Code of Ethics in 2012-2013, and his able secretary, Dr. Saha, who has been very supportive as well. I'm interested in thanking two people, Dr. Virendra Goyal, Professor of Pedodontics, who is the coordinator for these webinars, and Mr. Mukesh, an officer of the Dental Council of India, for having made enormous amount of arrangements and kept a good communication line running between us. It's very surprising that a government organization can achieve so much. Without much ado, I would like to go on to the topic for the day. It's about the informed consent document. Now, everybody knows that the informed consent document is an extremely important document, and in 1981, when I graduated with a BDS from Trivandrum, I'd never heard about the informed consent document, and I'm sure most of you in my age group would not have heard about it at the time of graduation. In 1986, when I had done my post-graduation in maxillofacial surgery, I remember encountering the informed consent document as part of the surgical file. And even then, it was one of those stock informed consents which are not even relevant today. So I'd like to place before you the format with which I'm going to go ahead with this topic. It's going to be only 40 minutes, or at the most 45 minutes, because I believe the attention span of a normal person is only that much. And during this period, I'm going to make you understand what an informed consent document is, and we'll tell you something about the special informed consent documents in these COVID times, and a slide or two about informed consent documents in research. Now, in 2015, there was this landmark judgment in the US where informed consent document became extremely important as a patient autonomy centered document, and any inadequate or absent informed consent became grounds for negligence. Following this, a spate of litigations began all over Europe and the US. And this particular information was released in March 2020, which says that absence of an informed consent document or failure to give an adequate informed consent document was responsible for a fourfold, there's a quadrupling of the number of cases and litigations which were filed. And there was a tenfold increase in situations where informed consent was one of the issues in our litigation. So this is really frightening, because even in India, we're going to have this problem over the next few years. With this background, we would just go into a short historical sketch to understand it. Now, all of us know that there are two words, informed and consent. The name of the document has informed and consent in it. Now, I'm very sure that through the ages, probably at the time of Sushruta or even Hippocrates and the medieval times, consent was always there. Patients always gave consent when they were going to be treated. But it never became a document, a legal document. And that legality was given to consent only in 1914 with the Schollendorf case. It took another 50 years for this consent to be made on the basis of information given to the patient. The doctor giving information to the patient based on which the patient took a consent. So that is how you have the word informed consent. They used jointly today to convey a very important meaning to the document. There have been other cases as well, and today as we know it, we know that a lack of an informed consent is adequate grounds for medical negligence. And this makes the informed consent a very important document in our medical or dental practices. So let's try to understand the what, when, why, and how of an informed consent. So what is an informed consent? Now, there is a definition for informed consent, which says that it's a consent given based on the explanation of all the risks and alternatives that is given by the doctor to the patient, based on which an unbiased information that is given, based on which the patient makes a consent and gives a consent. If you want to paraphrase the whole thing, it would come into 4 words. It's a consent based on information. Now, we saw this is required in a situation of risk. So we need to understand what is risk. Now, we all know, we all use the word very casually, but in a definition, a risk means a chance of an injury. Now, let's take each of these words. Now, what is chance? Chance is the possibility of something happening. Now, this happens very often in our practices. We know that if everything goes well, there is no problem. But every procedure that we do in our practice, whether it's dentistry or medicine, there are certain uncertain events that can take place. That is chance. And if that uncertain event takes place, it may cause an injury to the patient, which is something that the patient has no utility for. And that's called a disutility. So if there's an uncertain event and there is a disutility, it becomes a risk. So we need to understand what risk is. So the commonly asked question is, when do I take an informed consent? Now, this is a question that is always asked because people do not know in which situations do you take an informed consent, when do you not need an informed consent. The key word here is material risk. A material risk is what? A risk which would be significant. Now, you can't define significance because it's a very relative term. And the patient should understand this risk and the doctor should understand that the patient is understanding the risk. So let me give you some more clarity on that. So what risks are material? Which are the risks that you need to tell your patient? Which the possibility of that happening? Okay. So there is this test. It's not a black and white test. It's a very great test. It's called the prudent patient test. The key word in the prudent patient test is reasonable. So if you have 100 people, 90 of them are reasonable people. 10 of them may be outliers. So this reasonable percentage of people should consider that this risk is material, that it is significant. Now that's also called the prudent patient test. Now this only in a court of law, only a judge can make this assessment. Now I'm going to give you an example. As a maxillofacial surgeon, I'll give you an example out of surgery which dentists normally do in their clinics. Let's take an impaction, for example. Now, when you tell the patient that you're going to have a surgery and you're going to remove your tooth from the bone, a reasonable patient would expect some amount of swelling and pain after the procedure is done. And that because the operation was done inside the mouth, there would be some restriction in diet. And in many of the Western countries, these are done under sedation, so there might be some period of hospitalization, a few hours maybe. Forget about hospitalization. But swelling, pain, and a restricted diet is a reasonable expectation or a foreseeable expectation after an impaction. Now, there are several things which are unexpected consequences. Unexpected for the patient, not for the dental surgeon. Dental surgeon knows that several things can happen. Now, these might include, dilacerated tooth, a root may have to be left behind. It might be pushed into the lingual fossa. It might be pushed into the inferior alveolar canal. It can be pushed into the maxillary antrum. There could be neurosensory disturbances in the form of loss of taste or sensation on the tongue. Very deep impactions can sometimes cause fractures of the mandible. Now, these are not expected by the patient. So when they're not expected by the patient, it becomes an unexpected consequence. The doctor can expect them, and this has to be included. Now let me take you through some more. The informed consent is actually part of a contract. It is not a contract. A lot of people think that it's a contract between the patient and the doctor. No, it's part of a contract. Now, to understand that, let me explain what a contract is. Now, when you put up your sign in front of your clinic, it is an invitation. Every contract is an invitation, agreement, and execution. Now, you invite the patient into your clinic. The patient coming into your clinic has agreed to come in and get treated. you have given them the treatment plan, the patient gives you permission. This permission that the patient gives the doctor is the consent. Now this consent is based on several things, that's why it becomes an informed consent. Now how do they give the consent? Traditionally, all of us, I mean at least people in my age group, the traditional consent has always been a verbal consent. A patient comes in and you have a look and you say, okay, this tooth is badly damaged and you need a root canal or you need an extraction. The patient says, right doctor, I'll go ahead with that. And you ask them a history and get their medical background and you tell them that I'm going to give you a local anesthetic and extract the tooth. The patient has his extraction and walks out happy with his prescription. Verbal contracts are accepted in courts of law, but unfortunately, if there is a consequence of your treatment which is unacceptable, if you have a complication, even if it is something that happens as a sequelae to a procedure, like an instrument separation or a broken tooth or something like that, if it is not written, the patient may deny that a verbal consent was given. And that is the reason why informed consents these days need to be written. It's very important that you write down the consent that is given by the patient. Implied, of course, is a much more loosely used word, which means that when you ask the patient to open the mouth, the patient opens the mouth, which means that they have allowed you to examine the patient. So that's an implied thing, which is doesn't have much of significance in a court of law. But the expressed consent, whether it's verbal or written, has a lot of value, in which the written is the most important. I'm going to basically focus on that. So a lot of people ask me, why do we have this informed consent business? We were practicing, doctors and patients, very happily all these days. There was a good doctor-patient relationship. So why do we have this law? So there are legal and ethical reasons. And as we saw, there have been landmark judgments in several courts which have made it legal, a legal requirement today. So what is a legal requirement? It's a very, very simple legal requirement. Every person, at least in a democracy, has a right to take a decision regarding his own health and how it is treated by somebody else, how somebody else is going to, what they can do to him or do to him or her, or not do to him or her. And that is a right that every patient has. And every doctor has a corresponding duty to explain all the possibilities, benefits as well as the risk to the patient. Now this is the legal principle on which informed consent is based. But there is also an ethical principle. Now ethical principle is slightly different from legal principle because this is morality. So there are four principal ethical features: autonomy, beneficence, non-maleficence, and justice. Now, as far as informed consent is concerned, the most important one is autonomy, which means the patient's right to decide what is done on him or her. Of course, you have several others: dignity, honesty, and things like that. So, as far as an informed consent is concerned, autonomy as a central principle is the most important one, and it is a moral obligation from one human being to another. Since both the doctor and the patient are human beings, this is what is required. Now, autonomy is directly opposite to non-paternalism. Now, traditionally, doctors have been very paternalistic. In the sense, a doctor feels that whatever he says is right, and he probably knows what he's doing. But even whether he is right or whether he is not, ultimately it is a patient who decides whether you can do what is right or not right on him. So the patient's wish is absolutely supreme. So why dentistry? Now that's interesting because if you are having a heart transplant or if you are having a major cancer surgery, patients expect certain amount of morbidity and mortality. But not with dentistry. They feel that they can expect significantly. There are high expectations. The tolerance for an error is much lower. And dentists are generally considered to be very expensive. There's a high cost involved in this. So all of this makes dentists particularly vulnerable, and we need to be very careful in the coming decades. Another question that is often asked to me is, what do you include in an informed consent and what do you exclude? Now, that is a very sensible question. Now, the things that you include, let's say I'm going to take dentistry, virtually everything that's done in a dental clinic has to be included in an informed consent. Whether it's a denture, crown, bridge, root canals, extractions, whatever. Maybe examinations do not need to be included, and even x-rays, if you're using an OPG in a pregnant woman, you probably would need to take an informed consent. The others I'll come to in a couple of slides from now. Now, there are exceptions. So from what I said, virtually everything that you do in a clinic is open to an informed consent. Now, there are exceptions. Today we have the COVID infection, the COVID pandemic that is going on. And what happens in a COVID pandemic is that people are taken from their homes and quarantined. You don't need an informed consent for that. You can be forcibly tested. You don't need an informed consent for that. Now, if a patient has an arrest, cardiac arrest in your clinic, and you do a CPR and break a few ribs, because there is imminent death if you do not do that, you don't need an informed consent to do that. You don't waste your time preparing an informed consent there. Then minors or people who do not have the capacity to legally contract, that is, either they are very young or they are too old or they have a mental disorder, they are called incompetent patients. So they cannot give you an informed consent, so somebody else does it on their behalf. There's something else which is very interesting, which is called the therapeutic privilege, which is a very gray area. Now, sometimes, not so much in dentistry, but say in cancer and things like that, let's say there's a 20 or 30% chance that the patient will die. Now, making the person sign an informed consent with that kind of a gravity, a grave situation pending, is probably not a right thing to do. So, sometimes you may want their relatives to sign the informed consent. And very importantly and finally, there's something called a patient waiver. Now, autonomy means you have the right to decide what is done to you. That same autonomy gives you a right to not have something done on you. That is called a patient waiver. A patient can say, I do not want to hear the result of this biopsy. I do not want to know what you are going to do. I let my son or my daughter or someone else decide for me. That is also autonomy. So that is also a waiver, which is an exception for informed consent. Now, some of the informed consents that we normally come across, we think that it's not required, includes, like, for example, a CT scan. Now, in a small child, a CT scan may emit a lot of radiation, so you may not want to get an informed consent for that. People who have claustrophobia may find it difficult to go into an MRI gantry. So you probably require informed consent for all these. Now, HIV testing. Now, a lot of people, including me, we just ask them to have special serology or HIV testing done. You're not allowed to do that. You need to have an informed consent. There has to be a pre-test counseling and a post-test counseling before you give them the report. This is something that most people do not know about. Transfusion, blood transfusion, we think of it as an emergency, then that we can do it. But there are some religious sects which do not accept transfusions. Like, for example, the Jehovah's Witness, they do not accept transfusion. So you always have to get an informed consent before you transfuse blood or any blood products or even an organ transplant. Now, prescriptions in dentistry usually do not come under the scrutiny of an informed consent, but if you are prescribing something which is potentially dangerous, you may require informed consent even there. I've had an experience of actually prescribing carbamazepine for someone with trigeminal neuralgia, and the patient had a Stevens-Johnson syndrome and came back and said, why didn't you tell me that this drug could possibly give me this side effect? Of course, it didn't come to much. We explained that it's very rare and things like that. But if you are prescribing a drug which has potential harmful effects, you may even require an informed consent for a prescription. Now, most of us think that if we have an informed consent, then we are safe. Not really, because some informed consents are invalid in law. One of them is if you force somebody to sign an informed consent by threatening them. And if they can prove that they were threatened to sign it, it will become invalid. It becomes a human rights violation. If you are in a position, a higher position, let's say you're the employer and you tell your employee, you have to sign on this informed consent before I do it. And he may sign it and later say, I signed it because my boss told me to sign it. It is invalid. And then generalizations. In the old days, we had very general informed consents, which had the doctor can do anything to me. It may cause death. I accept all the complications, irrespective of whatever happens. I have complete trust in this doctor. That kind of generalizations and ambiguities are not accepted today as a valid informed consent. Now, in defense for the doctor, now one of the things that happens is that there is something called a subjective dissatisfaction, especially in aesthetic procedures like say dentures or a crown and bridge, and you tell the patient, we will give you a good, nice crown and bridge which will have good aesthetics. Now, what you mean by aesthetics is your perception of aesthetics. Now, the patient may not be happy with the aesthetics, although it fulfills all the standard requirements. So if the patient says, I'm dissatisfied with it, then that may not hold in a court of law, because a subjective matter cannot be brought into negligence. The other thing that you can take as defense is something that is absolutely unheard of happens during a procedure. That includes death. Very rarely do you have people dying on the dental chair. And if it happens and you have no idea why it happened, despite taking all the precautions it happens, then you call that a hand of God, the famous Maradona's hand of God analogy. And you can take exception in a court of law based on hand of God, where you do not know why it happened. There is something else that happens, that life or limb is not the correct word to use here. It is interruption of a procedure to get another informed consent. It's happened to me once. I was doing a vascular lesion and I realized at one point that the patient lost so much blood that we would have to do a resection. So my assistant held on while I went out and took informed consent to do a resection of the mandible, which was not there in the original informed consent. This could happen while you're doing a dental procedure. You remove one tooth and find the other tooth is also badly damaged, so you have to remove 2 teeth. You can always, mid-procedure, get an informed consent, or at least get leave in a court of law if that requirement comes up. So what is the relationship? By now you probably have an idea about what is the relationship between informed consent and negligence. Now, informed consent is closely associated with negligence. Let us see how. Now let's take the second one first. There are certain things that would happen as part of a procedure. For example, I'm again going to take an impaction as an example. Now, while doing an impaction, suppose 5 to 8% of people have hypostasia or paresthesia, a neurosensory disturbance. Everybody knows that. And despite taking all the precautions, suppose a patient develops paresthesia. Now, if you have an informed consent, then you can escape saying that the patient was informed that there is a possibility that it could happen. But if you have not taken an informed consent, it becomes grounds for negligence. But a lot of people think if you have an informed consent, that itself is a defense against negligence. No. Even if you have obtained an informed consent, and if you do a negligent act, particularly a grossly negligent act, you would still be held responsible for negligence. And if you are held responsible for negligence, the legal remedy for it is damages or criminal action or whatever it is. It is beyond the scope of this particular lecture, so it will be treated as a negligent act. So how do you prepare an informed consent? So there are some benchmark identification requirements in an informed consent. Like for example, the name of your clinic, the name of the patient, age, sex. You can even put in your Aadhaar card into the as a benchmark requirement. And then this is slightly wrong. It's not customized recitation. It is a non-customized recitation. That is a stock recitation saying that all kind of things, general things that would happen, that the doctor will examine you, he will do his best, he will try to save your tooth or whatever it is. Then specific to the patient, you need to make a a sub-clause specifically pertaining to the procedure you're going to do and the risks and the benefits that are going to accrue from that. And then, of course, you have the signature of the patient. If suppose the patient is a minor, the signature of a guardian or a next of kin. And if there are illiterate people, which would happen very often in India, you can actually read it out to them or explain it to them. But in those situations, you need a third-party witness. And these days, they even ask you to videograph it. And finally, of course, the signature of the doctor. And dentists famously don't date and time their documents. So date and time is very, very important if it goes into a legal situation. All informed consent should always be in the language which the patient understands, the vernacular language. There's no point in writing a informed consent in English and giving it to somebody who doesn't understand English. And the other two have already been dealt with. Finally, there are special informed consents. The important special informed consents that we use today are the videographs. In the US, more and more, particularly in critical cases, they use video recording. And even Braille has been used for blind people to read the informed consent. But of course, you can always tell it out to them, and if they can hear, they would understand what it is. Now, COVID, since March 2020, we in India are in the COVID era. There are certain modifications. I heard a WhatsApp of some Supreme Court lawyer saying that there is no difference in negligence in the period of COVID. No. Circumstances create exemptions. So during the COVID era, several of us did not practice. Some started practicing subsequently. Many people still do not use aerosols, and scaling is generally not done by many dentists. Now, all these can be brought into your informed consent. Now, there may be procedures. For example, the AOCMF, that is the organization which deals with dealing with trauma of the facial region, they have suggested that you try to avoid open reductions as far as possible and do conservative closed reductions or use self-threading screws to avoid splashes and saliva aerosols. Now, the same thing can be said about crown, bridge cutting and things like that. Now, if for some reason a patient says that I was not given proper treatment during this period, you can always raise the issue of a special informed consent being used to avoid that from happening. And there is also a patient safety disclaimer where you get a disclaimer from the patient saying that he has not tested positive or is not currently suffering from COVID. And the doctor should also give a disclaimer saying that he or she is not suffering from or has been tested for COVID-19. And if you are planning to have any kind of an alternate management, it needs to be clearly enunciated in a separate box and explain to the patient that you're going to change your line of treatment in view of the COVID situation. This is not an informed consent document, but this is a contract which I thought I'd just touch upon. It deals with a contract between the doctor and his staff. Now, the staff spend only about 6 to 8 hours in your clinic, and the rest of the time they are at home meeting other people. There might be social interactions, and they could pick up this virus anywhere. And they should not come back and blame you. It has happened in several situations. They have blamed hospitals and even dental clinics that they picked up the virus from the dental setup. So you need to have a disclaimer absolving you of having caused the infection if you own the clinic, in the clinic environment, and also absolving you of any financial responsibility for the same. It is a good thing to do, but always remember you have a moral obligation to insure the staff. There are plenty of COVID insurance available, so insure the staff and you can absolve responsibility. Finally, a few slides on informed consent in research. Now, if you look at the historical origins, in the 18th century, 1700s, and before that, there was absolutely no ethics involved in research and absolutely no informed consent. To give you the classic example of Edward Jenner. Edward Jenner called a young boy near his house called Fritz and said, show me your hand, and took. Before that, he had observed that people in the farming community who were closely associated with cows and who had cowpox did not get chickenpox. So, based upon this assumption, he took some cowpox material from a blister and injected it into this boy Phipps and made him suffer from cowpox, which is a very mild infection. Subsequently, when the smallpox epidemic was happened in his town, he took a little material from a smallpox victim's blister and injected it into the boy to see if he'll develop smallpox. And he didn't develop smallpox. So his hypothesis that cowpox would prevent people from having chickenpox, they formed the basis of vaccinations today. It has saved millions of lives. It also saved the life of Phipps. But there was no ethical standard, no informed consent. It was done on a young boy. That was the standard of informed consent those days. Phipps eventually grew up, got married, had 2 children, and even attended the funeral of Edward Jenner. But this will not happen today. So historically what happened? The same thing happened with Louis Pasteur. He was not even a doctor, in fact. So in the 19th century, they slowly started thinking that patients deserve some kind of sympathy. So the doctors among themselves would discuss whether it was safe enough for the patient. But they never thought about asking the subject, the patient himself, if they wanted to try something new on some patient. 30 years later, the Dumont paper came out, which actually said that you have to get a consent, not an informed consent, a consent from the patient before you try out any new drug. Now, these are the reasons why even the COVID-19 vaccination is getting delayed so much, because you have to go through a very elaborate process in having these vaccines out. Of course, they are cutting short. I think the Russian vaccine is cutting some corners trying to get there. There have been several other legislations, but principally you will notice that most of them started in the 20th century, mid-20th century, after the Second World War. And we have Indian legislations as well, which give the framework within which you take an informed consent. Now, the typical example of how informed consents were not used is of Joseph Mengele. You probably have heard of him. He was called the Death Doctor of Auschwitz. And he was responsible for some extremely brutal experiments on human beings, Jews who were experimented with and killed in the name of medical science. And as a result of this, and in fact I have been to Auschwitz, and it's a humbling and a terrible feeling to be there, to know that millions of people were killed in this place, and part of them were medical experiments done on Jews. It is not only the Germans, but even as late as 1972, the Tuskegee syphilis trials among blacks. You would notice that all these trials are done for poor people, marginalized people, African Americans, tribals, and Dalits, and there's been a lot of incidents of this kind of research work being done on people. And even as late as 1972 in the US, the people who had syphilis were not given treatment to see what would happen to them eventually. So there was absolutely no concept of consent. Of course, this resulted in the Kefauver amendments, which probably gave birth to a very, very strict principles in research. And in the Indian scenario, you have the ICMR today, which has laid down, some of these slides are superfluous, so I'm just going to go through them fast because they're not really very important. The CECHR, which is another body, laid down the guidelines for research and informed consent significantly. And there was also a bill introduced in 2006, which among other things laid down what are the things that need to be introduced in an informed consent for research. So in conclusion, I would say that informed consent is an extremely important document. You need to understand what it is, when to use it, the rationale for informed consents, and how to make an informed consent. You get plenty of templates on the internet. And if you expect a complication, then do not do the procedure without obtaining an informed consent. And you can make special informed consents for COVID times, contrary to what some of the lawyers have said. And informed consent for research is the same as the informed consent for clinical work, except that the criteria are much more stringent because you're doing it on normal subjects very often. Sometimes you do it on diseased people as well. So thank you very much. If you have any questions, you can direct them and I would be happy to answer.
Thank you, dear Dr. Joypal, for your wonderful presentation. I am sure that this will add to the knowledge of participants and will induce greater confidence in them. Now let us take up the questions put up by the participants. The first question is informed consent necessary for every procedure in dentistry?
Yeah, I think I answered that question just part of the presentation. Virtually everything, probably not for examinations, probably not for intraoral periapical x-rays, but particularly if you expect a complication, I think you do need to have an informed consent. It's becoming more and more necessary because there are a lot of litigation. So yes, almost all procedures.
If the informed consent is in another language, will the meaning change during transition?
Yeah, that's a good question because I said you need to use a vernacular language, and very often you have these standard informed consents on the internet which are in English or in some particular language. Now, when you want to translate them into a language which is your patient's language, and prepare a templated informed consent, you need to test it for accuracy. And the way of testing for accuracy is to translate it, let's say from English to Hindi, and then you need to back translate from Hindi back to English, and then look at the first English document and the retranslated document back into English and see if there is a difference in meaning between the two documents. So if there's no difference, then it can be accepted. That's how you need to actually validate translations in informed consent. Yes, you need to translate them into the language that your patient knows, yes.
Okay. If a child does not want treatment, can he or she be forced to have it by parents who have signed the informed consent on behalf of the child?
Well, that's a very interesting question because yes, the parent or the guardian is a person legally responsible for treatment. But look at a situation like this. Suppose you have a 14-year-old child who needs braces. And the child says, I don't want braces, I'm happy with my crooked teeth. And the parent says, no, you have to have braces. Can you actually force the child to sit on the chair and have braces? In fact, the child can sue you. There is a movie called My Sister's Keeper. If you see that, a 14-year-old child actually sues the parents for forcing the child to donate blood to a sister. So there is something called child rights and even rights of the unborn child. So when these are taken up, maybe not by the child, but somebody on behalf of the child can actually exercise this legal right. So although in theory a child cannot legally contract, a parent cannot force a child to do something, especially if the child is slightly older. A child which doesn't know anything, perhaps you can do something which is an emergency. But you need to be very careful. You're treading extremely dangerous areas when you deal with it.
Okay. In case of combined procedure by two different specialists, do we require to inform consent separately?
Yes, it happens sometimes. Pulpo-periodontal treatment, you have a periodontist and endodontist doing treatment. Each of them have separate risks in their procedures. I think you need two informed consents in those situations, or one informed consent that incorporates both of them. But in the surgical field, I can tell you that when you take a patient up for surgery, if there's an anesthetist involved, there's an orthodontist involved, there's a surgeon involved for orthodontic surgery, for example, you need to have a separate informed consent for each of these three people. And in routine surgery, if there's an anesthetist and surgeon involved, we take separate informed consents. Yes, you need two separate informed consents because the risks are different and the risks are dealt with differently. And until recently, you had this common informed consent where the anesthetist, surgeon, everybody signs on the same piece of paper. That will not hold good anymore.
Another question. If patient does not reveal hidden disease, would informed consent be considered invalid?
Yeah, see, doctors take defense in the informed consent saying that, we have explained to them all the possibilities. Now, if you have a patient who comes in with hypertension, if for any reason you have not actually checked the BP, and the patient hasn't told you he's hypertensive and he has a hypertensive crisis or there's increased bleeding or something like that, you can always turn around and say that as part of the history-taking process, they didn't tell me and therefore I could not include this particular complication as part of my informed consent. So it is a defense that a dentist can take, yes. But of course, all these are subject to your lawyer's ability to argue your position well. So you need to be careful. It's always good to pointedly ask questions and take a history.
Okay. Another question. In emergency procedure, can we obtain an oral consent?
In an emergency procedure, you don't need to obtain a consent at all. Like, for example, if the patient is unconscious, has a cerebral bleed, and the neurosurgeon wants to operate immediately to rescue that patient, and there is no relative or anybody nearby, they can do it. It is called there is a biblical thing, the Good Samaritan law in the US. So you can actually go ahead and do a procedure without getting a consent. It's just like one of the exceptions that we talked about. In a dental scenario, if a patient has a cardiac arrest, you can do a CPR. You don't need an informed consent to do a CPR. So even if you might break a few ribs, it would be exempted, yes.
Okay. So next question. What is valid consent in our profession?
I'm sorry?
What is valid consent in our profession?
A valid consent is a valid consent. An informed consent where you have explained all the risks and all the benefits and all the possibilities, including the possibility of no treatment, is a valid consent. Yes, I think it summarizes the whole talk, if you ask me, yeah.
Okay. What are the principles of informed consent?
I think those were explained, isn't it? You need, if there is a procedure to be done, you need to get a consent from the patient, and that consent should be based on the risks that are there inherent in that procedure, and what can be done if those risks happen, and if there is an option of no treatment again, which this basic principle is a consent based on information. I mean, in 4 words, consent based on information.
Okay. Next question. What does the consent form mean?
There's no such thing as a consent form. It's an informed consent.
Informed consent only. Okay. Okay.
It means exactly that. Consent based on information. Yes.
So, thank you. We have received quite a large number of questions, but unfortunately the time does not permit us to take up all these questions in this session. So let us take one last question. Incidentally, this is my question, dear George.
Yeah.
If someone refuses to sign the consent, what needs to be done?
Well, you can refuse treatment. You can say that I will operate on you or do a procedure on you only if you consent. By saying that I will not sign a consent form, it means the patient is not consenting, and the patient is not consenting, you obviously can't do the procedure. So there is no question of that happening. So if you say, I don't want to sign any paper, it says this is the protocol that we follow in our office, and so you have to sign it if you want me to do the procedure.
Is there any other option?
No other option. The verbal consent, if you want to take the risk, because a person who doesn't want to sign on a paper is probably the person who's going to go to court. So I think you should be doubly careful and even more vigilant about those people, isn't it?
Okay, we have come to the end of this session. Thank you very much, dear Dr. Joel Paul, for an extremely informative and very useful lecture. By listening to the excellent presentation, I am sure that we have gained a deeper understanding of the vital and essential aspects that will greatly benefit us.
Thank you very much, Dr. Janakraj Sabarwal. It was a pleasure to share this platform with you, my good friend. And I also take this opportunity to once again thank the Dental Council of India, its members, the EC members, the President and Secretary of the Dental Council, and all those people handling the webinar and for creating this platform and running it so efficiently. I thank all of them, and I heard that there are almost 20,000 people, or is it, I don't know whether that many people have tuned in. And to all those who are listening, I'd like to thank you for having given me the privilege of talking to you on this. And if you have any doubts that you want to clarify personally, you can email me on the email ID that I have given on the slide. And back to you again.